We'll move now to our next presentation. And our next presenter is Dr. Roxanne Kirsch. Dr. Kirsch is a pediatric cardiac intensivist at SickKids in Toronto. She has previously co-led the Surgical and ICU Learning Lab in the NPC-QIC and will be presenting a talk entitled Monitoring and Managing a Post-Operative Norwood in this ICU. Thank you, Dr. Kirsch.
Thank you so much. Thank you for this invitation. It's a real pleasure to be with all of you today. So I don't have any disclosures. I have a few objectives. I actually wanted to approach this maybe slightly differently than you might anticipate. Well, there's a wealth of literature that I could potentially go through or call upon. I think that most people have good access to that literature and have absorbed it quite readily, especially if they're engaged in taking care of single ventricles. What is probably sometimes harder to tell is some of those at the bedside moments of things that I find really important in over a decade of care with single ventricle patients. So here's where we often think that the ICU care talk is supposed to start. So you've got your patient, they're returning from the OR with their Norwood and an RV to PA conduit. And they haven't had a really eventful operative course and everything sounds good. So let's just tell me what my targets are and then we can all move on. And I'm going to suggest that we need to wait a minute and back up and look for all the other aspects of ICU care that are actually leading up to this moment. So let's not forget that all of our post-operative care actually begins pre-operatively. And if this patient is not actually known to your unit or team, you need to get a fulsome handover from your preoperative team. So I know that in some institutions, perhaps a NICU might be caring for the babies prior to their Norwood operation. So I think it's important to learn that patient's course and history. This is going to give you some of those nuances of anatomy and implications. Of course, as a cardiac intensivist, you're going to be involved in some of the decision making, and we'll come back to that. Knowing about the comorbidities and other organ systems will help you tailor their post-operative recovery. And you have to understand what issues they've had prior to coming. Of course, this also should give you some understanding if there's been prenatal counseling, if there's been discussions with the family prior to arriving at the moment of surgery, and you probably then can also interpret what you need to do and how you need to move through this course with some attention to family goals and values. So I'm not going to go into this because this in and of itself could be a 15-minute presentation, but just realizing that you may have a very different ICU course if you present unstable and need to escalate a lot of support prior to moving forward with your surgical intervention. And you might also often take a stepwise surgical report approach. So certainly if we had a patient who was slipping into high pulmonary circulation with a decreased cardiac output and poor systemic perfusion, we would move to do PA bands, bilateral PA bands, stabilize the patient, and then do a rapid transition to the full Norwood just to ensure that we have optimized organ function. So that's a common strategy that's used. Of course, there's many details we could talk about. I want to touch on the fact that, this is clearly the spitting image of Dr. Tweddle waiting to head off to do the Norwood operation. But you may have a few different options that you've thought about. And so certainly for families out there with patients with single ventricle disease, we may actually have to at times talk about different options besides the Norwood. And understand that there's a plethora of potential aspects of their baby's anatomy that have to be addressed prior to coming to the Norwood operation. Certainly the fetal lab with NPC-QIC has done a lot of work to discuss things like fetal intervention and fetal counseling. And this is all part of the continuum of care for the baby with a single ventricle. And then certainly, as you saw, a beautiful delineation by Dr. Tweddle of how he interprets which type of shunt to choose. In a similar way, there's influences to what surgical strategy you might choose based on the course of your patient prior to the surgical moment of the Norwood. This has already been reviewed by Dr. Tweddle. I'm just noting that there are institutions that will primarily do a hybrid procedure, and we're not discussing that today because we're very much focused on the Norwood operation, but just that there may be potential other options. And there's also often institutional preferences in how to move forward with some of these surgeries. So This is the stuff that you need to know, I think, as an intensivist. It's not just how do I take care of the Norwood after. You want to understand what the current expectations and risks of your patient are. That's why you should have a fulsome understanding of what's been happening with your patient. Ideally, you've been involved in the care of that patient prior to going to the OR, and you've participated in the decision-making with the cardiac center team in figuring out what's the best options for this patient. I do think that that gives you an ideal standing to come into care of the patient. So we all still have the same goals of surgical intervention, and ideally you've come out of the OR and Dr. Tweddle's checklist has been perfect and you actually have no residual lesions, but if you have them, you need to know what they are, certainly. And so I'm still not going to let you, I'm still a prairie girl going, hold your horses, because I'm not going to let you just give this very quick handover and then ask me what my targets are. I actually need you to do a fulsome handover. So this needs to be multidisciplinary and interprofessional. I know that the surgical teams that I've worked with and surgical teams of the other center are happy to do this with the anesthesia team. So the nursing team is involved. Everybody at the bedside is paying attention to what's been happening for that previous couple of hours in the operating room, because this gives you some of the nuance. Now, there may not be a lot of details to share, but by being in the habit of sharing what there is, you'll be able to better understand the times that things might be slightly different. It gives you an opportunity to ask Dr. Tweddle, for example, why he might have made a different choice than the one you perhaps expected. It gives you some anticipatory guidance for what you may want to set up to best manage your patient. I do want to give one warning. I have seen this many times. So you see the beautiful people chatting in a circle, look at their very collaborative conversation. And in the meantime, multiple things are happening to the patient and the monitors are going off and things are disconnected. And so just beware that somebody is still completely focusing every ounce of their energy on what is happening clinically with that patient, so that the attention to the very important handover details are not lost in that moment. This needs to be a safe space so that everybody can ask questions. I think that the fellows and trainees learn a lot when they're able to ask those questions of the surgical team or the anesthesia team to understand the choices that they make. And that helps them to move their learning forward. There is probably not just one way to do a handover. I think that NPC has several teams that would potentially share their information on how they do handover, but whether you're picking a checklist, whether you like to go chronologically, how are you telling the story so that the ICU team knows everything that's happening with this patient, that's already happened with this patient. Then we move into post-Norwood care, and I would love to take all the credit that so long as I've got you in my hands, I know all the medical details of how to take care of you, but this is a massive team endeavor, and you need your whole team focused on how to make this work. So you need to establish a shared mental model. Now, your shared mental model could be simple. It could be, this is a post-operative Norwood, let's take care of them. But I'm suggesting that what you want to form is a shared mental model of that patient's physiology, understanding all the information that you've already gathered on that patient. If there are residual lesions that have not been able to be dealt with in the OR, you need to know them, because this really affects sometimes my choices in targets or therapies, or how quickly I abandon trials of therapy that might be moving certain targets in one direction or another. And then also understand that whilst you establish a shared mental model, I've seen this happen before, you say, this is the physiology of the patient. Do not allow your team to get so narrow-minded that that's the only physiology the patient could say. We then need to figure out, oh, maybe the patient's changing. Maybe we need to shift our model. So I'm suggesting that while it's nice to have some algorithms so that you can do things in a standard fashion, I think that's very important. You also need to pay attention to what's happening with your patient. So you can't just say, set the inotropes at this, or the SATs must be this. You need dynamic targets, and you need a clear and open pathway for communication and follow-up. For me, this is beginning to be old-fashioned, which is perhaps getting hilarious because I'm really not that old, but I still like a solid clinical exam. And there are times when all the data pieces are flying at you and everybody's trying to tell you something, and you really just need to look at your patient and examine them and put all the pieces together with the patient in front of you. There is huge value to being present and to doing your physical exam, even if It doesn't give you the answer to the question. It helps you keep the pieces together and it helps you follow the course of your patient. So I still think this is one of your most important monitor. Now, well, there's a lovely new television series on nurses. I'm sure it'll be juicy and very dynamic. I do want to point out that there is nothing more important than a really well in tune with your patient bedside nurse. Besides the family support that Jenny has already demonstrated to us can be of so much value, that nurse can often give you some sense of, I'm not sure what's wrong, but I need you to re-examine this patient, or this has been happening, but I don't know if the team is still on the same model. Do we think this is the same physiology? And I recognize that across the globe, many people will be working in different systems. And whilst it's always lovely for me to insist that you should always have a fully trained cardiac bedside nurse under a certain training program, if that's not possible, there is benefit to adding some cardiac knowledge to your nursing program. And so there's different ways that you can go about it. I give our SickKids example because we have a beautiful nursing program that's very fulsome on an advanced cardiac learning program for nurses. But there's other ways to do this, and I'm sure many other systems have programs. So think about how your nurses are included in the care and the understanding of the patient that they're caring for. Everyone probably has some version of monitoring. This is the T3 from SickKids, but the point of me putting up this slide is that we can probably generally agree on some important ICU features of what types of monitors you want. We like to put them together. We like to see the trends. We can have heated debates on what monitors are best in what situations, but in general, with a Norwood operation, you want to have a lot of information because things can change quickly, and you want to try and catch details before they become dramatic so that you can have a chance to at least think about getting ahead of them. Watch out for your monitors. This is a teaching slide for my fellows, but I put it up here just because there's frequent times when my nurses are diligently doing a mixed venous sat, but the tip of the central venous line is actually into the RA. And so that saturation meaning is meaningless. So either stop measuring it or at the very least recognize that you cannot trust that data and that it's not reassuring in any way, shape, or form, and actually it's uninformative. There's always been talk about NIRS. I will share freely that I have taken care of hypoplast patients post-Norwood with NIRS and without NIRS. And there's certainly value in all the monitors. But one of the reasons to put this up, because this is clearly a valuable tool, is to also recognize that not everybody might have it. So one of the most important things for me when I'm thinking about how do I have my ICU team, how do I care for a single ventricle patient, is what do we have, what are we used to having, what do we understand? And then if we're using something new, let me understand what the downsides or what the potential problems are, and never putting all your eggs in one basket, so to speak. So it's lovely to have target data points. It helps you to sort of ground your team, but let's make sure that we then take that target data point and look at it in context with the full data. And for me, the clinical exam as well. I think this leads us into very easily an ICU axiom. As much as I try and make sure that we're not only running on dogma, I think this is the staying you can stand behind, trust but verify. So sure, this data is there, it makes sense, it's true, I'm certain it's true. Let's verify what might be going wrong once again. And it also, to me, sort of tips me in the direction of what might not be the correct piece of information. Because unfortunately, both two things may happen. Both the data just sometimes doesn't come together in a nice, clear picture. And sometimes our patients haven't read the textbooks that we have. And so they don't seem to follow exactly the way it's supposed to fit together. So you want to try and understand and always put together things in trends and as a full. And what for me happens when we have this data point that seems like, I thought the patient was doing so well. Why is the lactate rising? It gives me an opportunity to say, have I understood the correct physiology? Is the pulmonary blood flow higher than I thought? Are we having troubles with coronary perfusion? Do we have an arrhythmia that I didn't recognize because it's subtle? What is the patient bleeding? And we just haven't noticed that it's a bit more volume of bleeding than we thought. What is the physiology of the patient? What is happening at the bedside? And re-ask the question over and over again. So keep the blinders off and keep an open mind. Of course, your basic principles of cardiac ICU management for single ventricle apply, knowing that your cardiac output is now divided. So certainly this is critical. This becomes sort of second nature for those that do single ventricle care all the time. This is important to emphasize and reiterate for those that do it less frequently, so that you just kind of get your mind back in that mindset. And you're going to want to, in general, encourage systemic blood flow. And you really want to try and promote your systemic vasodilation. A very famous speaker who just spoke did a lot of studies to prove to us why we need afterload reduction after single ventricle care. And we've certainly replicated versions of this to demonstrate improvement in ABDO2, demonstrate improvement in cardiac index, demonstrate improvement in the total cardiac output for our patients, or for the total systemic output for our patients over the years. So this is important to understand, and certainly I'm a fan of afterload reduction. And I guess one of the things I would say is we do afterload reduction. Of course, you still need a coronary perfusion pressure. Of course, you still need an adequate blood pressure, but squeezing the patient back up, so to speak, so using a bit of pressure to overcome sort of an excess vasodilatory response is an easier way to tailor this than to not have appropriate afterload reduction. Transfusion always comes up. I was just at the Canadian Pediatric Cardiac Intensive Care meeting, which is going on concurrent to this. And we had a nice heated debate about transfusion in cardiac patients, and specifically single ventricles. And certainly the jury is out on there's a specific target that you should do. I think that perhaps I should say that differently. There is no jury out on a specific target. There's still some questions about times for when transfusion is helpful, and nobody's ready to abandon it and just leave our patients be relatively anemic. And there's certainly times, certainly pre-op, when you would not want your patient to be anemic. What's most important to me is that you're thinking about transfusion in the setting of what does my patient need, rather than what number do I want to see on the page. And so things like hypoxia will prompt me to often target a slightly higher hemoglobin, because it's going to help with your overall sort of buffer to make sure that your sats are adequate, your oxygen delivery is adequate, and it potentially gives you a little bit more time to manipulate other pieces of your patient, and then certainly ride out the phase that may be temporary. Perhaps their pulmonary vascular resistance is up, and you need to make some ventilator management changes if you have issues in the lung. Certainly transfusion for bleeding seems obvious, but also pay attention to how much bleeding. The number will never drop as fast as you need the blood. So in a bleeding single ventricle, I'm going to transfuse early despite the numbers, certainly with a mindset to all that lovely information anesthesia gives you, knowing what that hemoglobin was as they were just about to wheel over to the ICU. There's a nice study out that we should all read carefully. Certainly, this is also from the Tweddle-Hoffman lab, and the interventions that will help with your low cardiac output phase are, again, those things I feel very validated in this care pattern that I've always maintained, which is that improving milrinone and hemoglobin levels will reduce your low cardiac output state. So again, as I talk about transfusion and being careful about transfusion, if you're in a low cardiac output state, then you need to be doing manipulations. And it's lovely to have a number to know that, well, we don't really need to transfuse all the time to a specific threshold of 14. At a time when we're in low cardiac output, you may want to add transfusion to the mix of things to make an improvement for your patient. So in summary, for that piece of ICU care, single ventricle physiology is complete mixing, and you need to think about that and make sure your team is in the same model of understanding that. When your QP is anatomically restricted, which is what the intent post-Norwood is, hopefully not too restricted, but restricted, you can increase your cardiac output and increase oxygen delivery, and that's the best way to go about it. Predetermined drug preferences are lovely things, but they tend to be more dependent on how the operative course happened for your patient in a certain institution, some of the preferences of the team and how they're doing it, and some of your preferences for an ICU. For example, I realize that's being a bit vague there, but I've cared for single ventricle patients where the unit tended to have more of a tolerance for a slightly lower blood pressure target. Patients did fine. I've worked in a unit where they tended to have a slightly higher threshold for blood pressure numbers, also fine. So long as that patient has adequate cardiac output, they should do fine in both settings, but you may have a very different vasopressor inotrope dose at that point in time. I don't think that makes it wrong. I think the point of what I'm trying to get across is that it's what is happening with the patient and then titrate. So everyone will use inotropic support, but I think that it's important that you leave them in a titrated model. There's a lot of other aspects of ICU management, and I know a lot of these come through the phase 2 NPC-QIC key drivers, and there's several aspects we're working on. I know that there's still data sort of pending for this. This is just the Roxanne version in a very simple way, knowing that we'll be coming to time shortly. So for me, it's sedation should be as little as you can get away with. Extubation should be as early as you possibly can. For me, that's, are you hemodynamically stable, and is the only thing preventing continuing to move forward with your care extubation? It's definitely time to extubate. Delayed sternal closure does delay everything in the ICU. So if it's not necessary, and certainly there's indications for why it might be necessary, but in my view, as the intensivist, if it's not necessary, don't do it. It only slows things down, and I don't have a perceived benefit in prophylactic delayed sternal closure. I think that your team approach also means that your team needs to be prepared for problems. There will be problems. It's lovely when the patient flies through with barely anything to talk about, but that is just not the norm. And so you want to make sure that you've both thought about all that preoperative knowledge you have of the patient so that you can anticipate problems, that intraoperative knowledge you have so that you're on target for what sorts of problems might come up, and that you're communicating expectations. Some of the things that I communicate to my fellows are just what I expect for this particular patient. So I've added my lens of experience and my lens of how we targeted the patient's physiology. And then I also give them sort of the next number of hours I expect this to be happening, which also sets them up to go, well, that's not at all what Roxanne expected to happen. I better call her. So it gives us another point of discussion to look at that patient. And then certainly some of that conversation for me in preparation for problems involves very early conversation with the surgeon. So Dr. Tweddle wouldn't be off the hook after coming out of the OR, and whilst he'd likely be checking in on his patient regularly, I'm also probably communicating with him regularly, particularly if we have a patient that has some residual lesions or one that's clearly going to have a bit of a rocky postoperative course. You want to be attentive ahead of time so that you can try your best to anticipate problems that might come and prevent them where possible, and get on top of correcting them or changing them or mitigating them as soon as they happen. This is a note just extra especially, and I think that it would be a whole training session in itself. Communication is vital to your team, but communication to the family is also vital. And don't forget to make sure that you have good lines of communication, that you have knowledgeable people able to answer questions for the single ventricle patient families. This is a journey that we all take together, and remembering that and doing a massive team approach is the best way to get through it. Team endeavor, I think I've harped on that well enough. Know your preoperative, intraoperative picture. Make sure you pay attention to the patient while you're hearing about anything handovers wise. Target your therapies for physiology. I cannot say it enough. And prepare for problems in advance wherever possible. Thank you so much for your time and attention. I really appreciate the opportunity to talk to you all.
Well, thank you so much, Dr. Kirsch. That was a wonderful talk. And thanks to all of our speakers today. We have just a couple minutes left. I do want to say we have one comment from the Q&A for Dr. Kirsch, that we love the terrific focus on teamwork with a thumbs up okay. And then we have a second question. Are OR perfusionists involved in the post-op handoff at your institution? And do you think they should be part of the multidisciplinary team at the time of handover post-op?
What a great question. So in general, my perfusionists aren't. They're moving on to set up bypass for the next case. There has been an occasion where they've come down to sort of relay a specific piece of information. In general, the information they might have to add to the scene is translated through the cardiac anesthesia and surgical team. But certainly, I think that having everybody's point of view and being on page and being able to have an opportunity to add their nuance to the case could be beneficial. So it's going to be a little bit of what works for your center. So certainly, I know that everybody has to modify for what works for them, but I think it's a great idea and a great question.
Great.
I'm going to go back to my team with it.
Good, like that. Okay, here's one more really great question. It's a two-parter, but first, how transparent are the surgical team with intraoperative events, particularly if there were complications? Secondly, how much have you encountered anchoring bias based on the surgeon or anesthesiologist's interpretation of events that occurred in the OR?
Oh, such good questions, team. So actually, we have a very transparent team about problems and complications, and there's that version of events where everybody that's used to taking care of cardiac patients, and there's a very worried, very new trainee who's like, oh my gosh, there was arrhythmia, and everybody's like, it was mechanical manipulation. Do we have to keep talking about this? We expect it to happen. I think there's still value in hearing that part of the story, and then you reassure your learner that that is a normal course of events. And so everybody's very clear with what happened. They're completely transparent with what happened and what they did about it, and we just own that not everything is going to always turn out perfect. Are there anchoring biases? Yes, probably you can see them happening even in your own team. And so I think the only way to undo that is to always question if we're just traveling down a path of this is the physiology because anesthesia told me it's a physiology, or this is the physiology and these 5 data points also suggest that that is a correct statement. So re-question your presumed mental model that's coming out of the OR. There are on occasions in my team that intraoperative events are happening and issues are going on, and I'll get called into the OR, which I find supremely helpful because whilst I may not be able to hands-on help to do anything at that time, it helps me to interpret the data with them and for us to build a shared mental model together that I can then translate to my team. So I think that's the other way to get around one person's bias in exactly what's happening.
That's so great. We have more great questions coming in, but we are at time, so I'm going to wrap us up here. Thank you so much to everyone who presented today on behalf of the National Pediatric Cardiology Quality Improvement Collaborative, NPC-QIC, it is a lot of letters, and the Fontan Outcomes Network, or FON. We'd really like to thank all of our attendees and our presenters as well. We really appreciate these excellent questions coming into the chat. I wish we'd had more time to answer all of them. Thank you to Hart University for hosting this learning series. And thank you also to the Academic and Research Committee grant at Cincinnati Children's for funding these webinars. We hope that you will tune in for our next webinar, which is on December 10th, and it's entitled Surgical Considerations in Fontan Patients. Thank you very much to everyone.